Hi everyone, it's Tammy Sharrow, and today I'm going to be talking about health alterations that are common in school-age children. If we remember growth and development with school-age children, when we think about Freud, it's the period of latency and the importance of privacy and understanding the body. Typically, they're seeking peer acceptance and usually with same-sex friends. Certainly that can change in early junior high. Erikson, it's the period of industry versus inferiority, and they gain self-worth from involvement in activities, specifically extracurricular activities. They love to acquire new skills and knowledge, so really important component for kids to be able to have that opportunity. And as far as Piaget, they're in that concrete operational stage, starting to develop logical thinking, cause and effect is established, and now they're able to consider alternative solutions and solve problems. So our objectives are to understand the similarities and differences between asthma, allergies, and anaphylaxis, to explain the patho of asthma and how this relates to the signs and symptoms, to identify management of acute and chronic asthma, going to look at the PRAM score and asthma pathway, going to talk a little bit about medications used to treat asthma, and really important to understand the importance of education and the use of asthma action plans in managing asthma at home and in the school setting. Begin by looking at anaphylaxis. And anaphylaxis is a severe hypersensitivity reaction with typically rapid onset and has the potential to be fatal. In Canadian children, the three main triggers for an anaphylactic reaction are food, insect stings, and drugs. The most common is food, and the most common allergens are to milk, peanuts, and tree nuts. So food allergy affects approximately 7% of Canadians. So in establishing the diagnosis of anaphylaxis, we're looking for any acute onset illness with some of the typical skin features. So rash, swelling, flushing, all of those kinds of things, hives. Plus, we're looking at airway problems such as airway narrowing. Wheezing is probably one of the most prevalent early signs, upper airway obstruction, and sometimes nausea and vomiting can come along with an anaphylactic reaction. And then like the total body reaction as far as things like hives, urticaria, the swelling, sometimes pallor or paleness. They can feel a sense of doom and certainly can even lose consciousness. So I wanted to share with you a story, Sabrina's story, and you can hit the link on the basic PowerPoint slides. But Sabrina's story is about the girl and the allergy law. So Sabrina was a 13-year-old girl who knew she had specific allergies to milk. And she was, I believe, in grade 7, and she wanted to have the French fries in the school cafeteria like all her friends were. So she decided to sample them, and she was fine. She didn't have a reaction at all. Then a few days or weeks later, I can't remember exactly, she decided to have the French fries again, and this time they were contaminated with milk or dairy, and she had a profound anaphylactic reaction. And at that time, they didn't have anaphylactic protocols in the school that she was in. She ended up having a respiratory and cardiac arrest. Her EpiPen was in her locker. No one seemed to know the combination. They weren't able to retrieve it. 911 was called, but Sabrina ended up passing away. And so her family fought long and hard to develop a law, a policy, a procedure around anaphylaxis and the management, specifically within schools. And so the law took effect January 1st of 2006 and required school boards to have all principals implement anaphylactic plans. And the key things that these plans needed to include would be strategies to reduce exposure to allergens. So that might be something they needed to do within the school setting or within the classroom. Procedures to communicate to parents, students, and employees all about life-threatening allergies, and regular training for specifically probably teachers and staff on dealing with life-threatening allergies. So if a child presents with one, what is the action they're going to take? And so now all children will have access to an EpiPen within the school setting. Most kids have their own, and they may carry them on their person for sure when they're old enough to be responsible. They might have a little fanny pack or a purse that they carry with them. And then for younger children, it might be on the teacher's desk or something like that. But anyway, all schools now have this plan to prevent this type of thing from occurring. There is a link on the Blackboard site to a really interesting group, TREC, and they're beginning to develop evidence-based protocols for dealing with different health issues. And so TREC stands for Translating Emergency Knowledge for Kids. And there's a link to one on bottom line recommendations for anaphylaxis. It's a brief little 2-pager, but it's got some excellent information and resources on dealing with allergies specifically, in the community and in the ER and hospital situation. Okay, so let's move on to look at asthma, and to make the link with allergies and asthma. Children with asthma often have allergies and vice versa. So they're kind of interrelated. So it's not uncommon that a child with asthma might have food allergies or other triggers. So asthma, what's the incidence of asthma? Well, as I mentioned, it is the most common chronic illness in children. And typically the peak time for asthma, interestingly, is in the fall. With the start of the new school year, kids are in close contact with each other, and germs like common colds are spread more easily. Colds are the most frequent asthma trigger in young children, and they cause up to about 85% of exacerbations. Now, interesting to see if there's less asthma with COVID restrictions and wearing masks in class. Are kids getting the cold less, and are there less asthma exacerbations? So September is typically the asthma peak. Some of the things that also happen is that children often have been not as compliant with medications over the summer, and then they come back to school, they catch a cold, and they're playing a little bit of catch up on their medications. Approximately 20 to 25% of annual hospitalizations for asthma of children in Canada occur in September. And it usually peaks about 18 days after Labor Day. So, impact of asthma on the child and family. Well, asthma is a chronic disease, and so some of the impacts on the child can be their lifestyle, their activity levels. They might have increased absenteeism from school. They may need to take medications on a regular basis. More common that they would have ER visits and hospital readmissions and have missed school. Impact on the family is just that notion of managing a child with a chronic illness. And so often the family manages the asthma when the child is young, but as they move to school, the child needs to become more self-reliant and be able to develop their own self-management skills, to understand when they're having signs and symptoms, how to triage themselves, when to ask for help, when to take their medication, etc. So it can be concerning and stressful for the family. There can be uncertainty around raising a child with asthma. So asthma is a reactive airway disease. It is a chronic inflammatory disorder of the airways, and it causes varying degrees of obstruction and narrowing in the airways. It can be recurrent, so it can happen time and time again, especially when exposed to their particular triggers. However, it is reversible and with medication. So tends to be these episodes of wheezing or difficulty breathing caused by the airway obstruction. Common risk factors can be familial predisposition. Asthma tends to run in families. Certainly exposure to smoke, secondhand smoke, specifically in the home or a car. House dust and mites can be a risk factor. Interestingly, preterm birth can be a risk factor. Children who've had RSV and pets and pet dander are common triggers for asthma. So just a little visual of the pathology of asthma. So you can see the narrowed airway. So we've got a picture of the normal airway, and then we have a picture of the asthmatic airway. So even when they're not necessarily in an asthma attack, they may have, their airway may look different than a normal airway. So the first two pictures have very relaxed, smooth muscles, whereas the picture on the right, you can see there's a tightening of the smooth muscles, narrowing the airway further. You can have the walls inflamed and thickened. And also mucus production is another common occurrence during asthma attack. And you can see too at the picture at the far right, how there's air trapped in the alveoli due to the sort of hyperinflation and the obstruction and narrowing of the airway. So some of the signs and symptoms, asthma, the onset can be gradual or it can be very, very abrupt. Some of the early signs, I like the little acronym, can't wait till spring. And those early signs are often coughing, wheezing, specifically on expiration as an early sign, till tightness in the chest. They may complain of their chest hurts, and then shortness of breath or some sort of dyspnea. Increasing distress comes with wheezing on inspiration and expiration, diminished breath sound, so we're not hearing that nice equal air entry into the lungs. Tachypnea, increase in the respiratory rate. Now we're starting to see the use of accessory muscles, specifically the scalene muscles, which are part of in the neck. We'll see retractions. This is where the child might become more anxious, restless, agitated. and might put themselves in a position where they're best able to ventilate. So certainly in a school-aged child, we often talk about the tripod position where they sit upright and lean forward. They do not want to lie flat. And then ominous signs where we are really getting concerned is if the chest is quiet. So we're not hearing breath sounds at all, head bobbing, which is more common in younger children that have, poor developed neck musculature. Further use of accessory muscles, increased work of breathing, and now we see some changes in the CNS, moving to lethargy, confusion, disorientation. So, management of acute asthma, certainly in the hospital setting, some of our investigations might include a chest x-ray, just looking to see what's happening. Is there any secondary issues that could be going on, any infections? Blood gases can be helpful, and we often use pulmonary function tests. Now, if a child comes in and is in a lot of respiratory distress, we don't use pulmonary function at that time. That can actually make things worse. Humidified oxygen, we'd follow their pulse oximetry very, very closely. Obviously, frequent full sets of vital signs. Hydration and IV access can be important. So sometimes they may not, if they've had a cold and it's been leading up to their asthma attack, they might not be well hydrated. And sometimes asthma can deteriorate or change really quickly, and we often want IV access for medication administration. So if they came into the ER and they were in a fair bit of distress, I wouldn't be surprised that they'll pop an IV in as well. Positioning, always putting the child in a position where they're best able to ventilate, so increased head of the bed, or just allowing them to sit upright and lean forward in that position where they're most comfortable. We reach for our quick relief medications in this situation. We're going to talk a little bit more about that coming up. Bronchodilators and anti-inflammatory agents. So we want to open up that airway and decrease the airway inflammation. Usually bronchodilators, we start with inhalation, but at some point, if the airway is too obstructed, those medications just can't get to where they need to, and we might begin to provide IV bronchodilators. So there's such a thing as IV salbutamol. And as far as the anti-inflammatory agents, we might start with something like oral prednisone, but might need to move to IV steroids to get the absolute best effect when the child is in a fair bit of distress. And then, of course, we're monitoring the airway response to treatment with frequent assessments pre and post meds. There's a link here to the asthma pathway. So the asthma pathway is a objective tool used to assess a patient or child with asthma and to be able to decide on frequency of assessments and frequency of medications. I don't expect you to memorize the asthma pathway, but just to have an appreciation. It's used throughout Alberta. And so a child with asthma who goes to the Peter Lougheed, to Alberta Children's, to Medicine Hat, to Lethbridge, to Edmonton, all will be treated the same. And what this provides is consistency in treatment and objective measurement as far as severity. So it is an evidence-based pathway. It's research-based and is very, very effective in moving children along the pathway to eventually improve and be ready for discharge. So I wanted to introduce to you the PRAM tool, the Pediatric Respiratory Assessment tool. It's an asthma clinical scoring tool, and this is commonly used at Alberta Children's Hospital. A lot of pediatric centers use this. And so it's a combination of looking at suprasternal indrawing, or what we kind of know as tracheal tug. It's looking at scalene retractions, which are the retractions around the neck musculature, the scalene muscles. We're looking at wheezing, and we're looking at air entry. Now, in Alberta, we use the modified PRAM score, and we don't include oxygen saturation. So we would include just indrawing, retractions, wheezing, and air entry. And we would come up with a score. And you can see on the bottom here, you've got mild, having a PRAM score of 0 to 4, moderate 5 to 8, and severe 9 to 12. And then obviously anything 12 plus, we've got really impending respiratory failure with increasing hypoxia and a rising PCO2. So in the case study we will look at PRAM score, the PRAM score tool, and actually assess a child with asthma. Pardon me. Let's talk a little bit about medication administration. So what we know from the research is that few parents use kids' asthma meds correctly. There's typically about a 10-step process from the minute you pull out the medication to how you prepare it, to the administration, how long you wait before you give it again, all those kinds of things. And so, it's common for parents to do this incorrectly, and so very common that kids would do it incorrectly as well. So one of the main types of medications we use are what we call the relievers, or the rescue medications. And these are typically short-acting beta agonists. So classic example is Ventolin. And this causes a relaxation of smooth muscle, increased bronchodilation, and mucus clearing. So a reliever medication might be something that we would hope most kids wouldn't take daily. If you have exercise-induced asthma, you might use your reliever before you stepped on the court or went onto the ice if you played hockey, or before you went out to play soccer. But it's not something we want children to be using daily. If we're seeing an increase in reliever medication use, that usually means that there's an asthma flare coming and the child is their asthma is out of control. The other main group is the preventer or controller medications. And these are typically corticosteroids, so they're inhaled. An example might be Pulmicort, something like that. When they have a significant flare and might end up in emerge or hospital readmit, sometimes we will use oral corticosteroids, but typically in the home setting, we use inhaled corticosteroids. These are typically taken daily, and hence the name preventer or controller. They prevent or control that airway inflammation, reduces mucosal edema, and can also help to control seasonal allergies. So this is a really important grouping of medications. Parents are often concerned about their child being on, long-term daily steroids, but the research would say that there is no impact on growth. That's what most parents are worried about, and that it actually really, really helps to control asthma and improve asthma and prevent things like flares, ER visits, and hospital readmissions. So as far as current asthma treatment, when is asthma in control and not in control? And one thing we're going to look at coming up is the written asthma action plan, and that usually provides information for the child and family about when they may be getting signs and symptoms or hints that their asthma is not in control. And so asthma is in control if we have symptoms 2 or fewer days per week. We only have nighttime wakening once a month. We don't want children waking up and coughing at night. That tells us our asthma is out of control. There is no interference with normal activity or exercise. And they're not using their Ventolin puffer more than 3 times a week. There's another little measure we use, the peak flow, which we'll look at in a couple slides, which can be a really good objective measure as to how whether your asthma is in control or not. And ideally, we want no more than 1 acute asthma attack per year. So the peak expiratory flow meter is something that parents can be provided and take home and use at home, and it gives them an objective measure of their child's asthma symptoms. And parents find it really empowered them to be able to assess how their child is doing, if their asthma is in control, and that they were able to initiate treatment earlier than without the asthma peak flow meter. And so we like to see peak flow results greater than 80%. And if they start dropping below 80%, it is a sign that asthma might be out of control. Some asthma action plans actually ask you to record your peak flow values, and that would be useful information when you go to see the doctor that's following you for asthma as an indicator of how you're doing. So one of the last things I want to touch on is the written asthma action plans. I've got a couple images of different ones. They have one specifically designed for younger children, sort of under 5 or 6, and then designed for older children, school age and above. There's been a lot of research done on the effectiveness of written asthma action plans in improving asthma control and reducing ER visits and hospital readmissions. Some of the latest work they're doing around written asthma action plans is developing an app that would provide that information, so you don't have to have a piece of paper in your pocket, or your mom has to have it in her purse, that you can actually have access to it on, say, your cell phone as an app. This would be particularly effective for older children or teens with asthma. And there's some interesting research happening on that right now. But typically, the research would tell you that when children have and follow an asthma action plan, their asthma is in much better control. All right, thanks everybody. Oh, there's a link here which you can get on the regular slides, and that is to resource, which is the I Can Control Asthma Now, or the ICAN website. This is an Alberta Health Services website, and it is a phenomenal resource for kids, families, and healthcare professionals around asthma. There's videos, there's tools, there's the latest research. So it's a really, really valuable resource for not only kids and families, but healthcare professionals as well. All right, thanks.